This is video 2 related to our pediatric skeletal disorders. So we're going to be going over pediatric skeletal disorders requiring intervention during skeletal growth, structural abnormalities that may develop. Some conditions require medical evaluation, treatment, and often immobilization, such as pediatric fractures, abnormal spine curvatures, osteomyelitis, developmental dysplasia of the hip, and our clubfoots. The clinical importance of all of this, early identification and management helps to prevent impaired mobility, pain, long-term deformities, and functional limitations. Fractures in children overview. All right, so a fracture is a break or disruption in the continuity of the bone. It occurs when force exceeds bone strength. Um, Common in children, it's not that common in children just because their bones are a little bit stronger, but it can occur in children when we have increased mobility, immature motor coordination, and their limited risk of awareness. So the etiology of a fracture, we have accidental trauma, which would be, falls, sports injuries, motor vehicle crashes. We can have non-accidental trauma, which is child abuse. And that always needs to be considered when the injury does not match the history. And when we talk about spinal fractures, I'll get into that a little bit more. And then we have pathological fractures, and that would be due to a fragile or weakened bone. So we see this in osteogenesis imperfecta with bone tumors and bone cysts. Your clinical importance. Timely and thorough assessment is essential to prevent loss of function, avoid growth disturbances, protect that epiphyseal growth plate, and understand an injury and the location of fracture for treatment decisions and risk of complications. So the first fracture is a transverse, which is a break at the line, and it occurs at right angles to long axis bones. This is not a common fracture that we see in children because it takes a lot of force on a child's bone to create that type of fracture. Oblique, this is a diagonal or slanting break that occurs between the horizontal and the perpendicular planes of the bone. Again, not commonly seen. Green stick fractures. Now, these are something that when we see fractures, these are a little bit more common. The break occurs through the periosteum on one side of the bone while only bowing or buckling the other side of the bone. So these are like incomplete fractures. I like to think of this like a stick off a tree. If it's a green stick, a fresh stick, we can kind of like bend it and it might splinter a little bit, but it's not going to break all the way through versus maybe an old dried out stick that we can just like crack in half, right? So adult bones more commonly crack in half. Kiddo bones, it has increased flexibility due to that thicker periosteum, and therefore we don't have full complete breaks. Spiral fracture. So this is where we actually see the twisting motion that occurs. This is commonly seen in child abuse. So again, if you had a parent who told you, like, oh, I accidentally closed their arm in the car, we would expect to see maybe a complete fracture, maybe a green stick fracture. A spiral fracture means that somebody had to like pull and pull and twist hard enough to actually create that fracture. So simple fractures and compound fractures. Simple fractures is when the skin is still intact. The fracture still requires us to do a really good nursing assessment because just because the skin intact does not mean that we might not get additional complications. Bones are very vascular, so we can lose a lot of blood. If we have too much swelling from the injury, we can get compartment syndrome. which can lead to neurovascular compromise. When we have a compound fracture, this is also sometimes referred to as an open fracture. So we have disruption of our skin and our subcutaneous tissue and our muscle where the bone is now, open. Infection is a high risk because from that opening, we have the chance for microbes to go down into that bone. So children are at risk for blood loss because of this and infection because of this. Differences in pediatric fractures. So again, pediatric bones differ from adult bones. They are less brittle due to their higher collagen content. They have a stronger periosteum, which reduces their displacement. They have the epiphyseal growth plate, which is going to be the weakest point of the bone. And if you have a child that has a fracture at a growth plate, we need to be very careful with follow-up on that because if that can actually change their growth trajectory and it could shorten that extremity if it's not handled correctly. Additional growth and development considerations. Fractures in infancy are uncommon. So we have concerns of abuse or neglect. When fractures occur in children, it could be a birth trauma or it could be that non-accidental trauma, which would be the abuse. It could be that the child has some underlying pathophysiology that hasn't come out yet, like osteogenesis imperfecta, where these kiddos get frequent fractures and their bones are really fragile. So any fracture occurring after the newborn period should be evaluated carefully to rule out child abuse or to rule out some underlying pathology. Common causes of pediatric fractures. Falls are the leading cause. Children intrinsically extend their arms to protect themselves, and we can get issues due to that. Impact typically transmits from that upper extremity and then can affect the wrist, the elbow, and the shoulder. Supracondylar fractures, which is an elbow fracture, is really what gets associated with that intrinsic ability to put your arms out because they put their arms out and then the impact gets transmitted to that elbow, and then we end up with that supracondylar fracture. So what's the response, right? We get the fracture and immediately we have bleeding from the bone and the surrounding tissue, which then forms a clot and fibrin strands develop and create a framework for healing. Bone repair process, osteoblasts proliferate at the fracture site, increased osteoblastic activity forms new bone matrix, calcium salts are deposited, forming a callus. The callus provides stability and support. Callus is gradually replaced by new bone tissue. Pediatric advantage, remodeling occurs more rapidly in growing children. Are systemic risks associated with fractures? In long bones, we can develop fatty embolisms, which fat droplets from bone marrow can enter the circulation and cause respiratory distress and neurological changes. We can also end up with hypovolemic shock because we can have excessive bleeding, which could lead to signs of like pallor, cyanosis, shallow breathing, and decreased level of consciousness. Growth plate injury, again, if we have an injury of the epiphyseal plate from a fracture, it could lead to growth disturbances or a limb length difference. So we just need to be mindful of that and make sure that those kids are getting appropriate follow-up. Our assessment for this, our initial assessment, we want to make sure we obtain a history of the injury, the mechanism of trauma. We want to inspect the fracture for bruising, swelling, skin lacerations. How's their movement and range of motion? Are they protecting or guarding the injury? And then don't forget your 5 Ps from fundamentals. We want pain. Is it severe? Is it unrelieved? Or is it worsening? And when we talk about compartment syndrome, that's usually pain that's out of proportion to the injury. Then we can have pallor. so the paleness. We can have pulselessness, which is deep or absent distal pulses. We can have paresthesia, which is numbness and tingling, kind of that asleep feeling. We can have paralysis, which would be the inability to move the extremity. Abnormal findings of any of these really require immediate intervention to make sure that we don't have permanent impairment develop. And when we're assessing for other potential complications, that fat emboli, although it's rare in children, it's possible after a long bone fracture. We can get petechiae, hypoxia, and pulmonary infiltrates. We want to make sure that we're treating and we're supporting. That's going to be an ICU patient, very complex. We also want to make sure that we're preventing any deep vein thrombosis. So we want to elevate the injury, early ambulation when safe, post-operative physiotherapy. And again, DVT is rare in children, so we do not have a standardized pediatric prophylactic guidelines like we have in adults, but it doesn't mean that they can't get them, and your role as a nurse would get them moving as early as possible and to assess for that. Pain management, it's really essential to promote healing and reduce our hospital stays. We want to use age-appropriate pain scales, and we want a multimodal pain control. This isn't just, a one-size-fits-all. It's going to be really tailored to your kiddo. Cast care is another big one. They have to keep the cast dry and clean. They need to not stick objects in it. If anybody's ever had a cast, they know how itchy they can be. Sometimes a blow dryer on cool heat will help with that, like on cool air. That can help with that itchy, but sometimes kids will like try to stick stuff down in there, and that can lead to skin breakdown and infection, and really infection to the point where they can get osteomyelitis, which will be the next slide we talk about. We want to make sure that we're elevating the extremity for 24 to 48 hours. And then the big thing is cast removal. If the child had never had a cast removed, you need to like prepare them that that cast is super loud, but it just vibrates and it's not going to cut the skin and it's not going to hurt. Um, and then, of course, like all of this education needs to be given to the parents in a way that they can understand it and make sure that they're helping to keep it clean and dry and monitoring the kids for sticking things down it and follow up and preparation for when we remove it so that the child's not upset by that very loud saw that just vibrates. All right, osteomyelitis. So osteomyelitis is an infection of the bone or the bone marrow tissue. The pathophysiology, organisms can reach the bone through bloodstream, contagious spread from nearby infected tissue. So if we have an infected wound or an infected joint, or it can be from direct, so from an open fracture, from a surgical wound, or maybe we put like pins or wires for skeletal traction, and that's like a direct line into the bone. The clinical importance, infection associated with skeletal traction hardware is really significant nursing concern. This can lead to, them getting osteomyelitis, and the last thing that we want is for a child to end up getting amputation because the bone is too destroyed from infection. So early recognition and treatment are critical to prevent chronic infections, bone destruction, and growth disturbances. So what does it look like? In an infant, symptoms could be really vague, nonspecific, like fever, irritability, lethargy, poor feeding. Some infants could present with sepsis. In our young children, they're going to have localized signs of pain, inflammation, warmth, tenderness, unusual odor at the infected site. If there's a wound present, is really specific. So if they did have hardware and now that hardware is starting to kind of had weird foul smelling drainage and odor, we can have systemic signs of fever, irritability, and lethargy. In our older children, we're going to start to see more specific things because they can articulate it better. So they're going to be having pain over the infected site that they can tell you about. They're going to be favoring or guarding, limited range of motion, tenderness, erythema. And then we want to look for those systemic symptoms again of fever and lethargy. It's really important for us to note if they're having radiating pain into a nearby joint. That could indicate that they also have septic arthritis, which requires immediate intervention. Nursing care for osteomyelitis. History, first and foremost, right? We want to make sure that we obtain a comprehensive history. So, recent infection, recent dental history, because again, poor hygiene increases the risk of bloodstream infections that could spread to the bone, any recent trauma or falls. In the adult world, a lot of times we see osteomyelitis with our people that like to use IV drugs. Physical assessment, we want to inspect and palpate, pain, tenderness, erythema, swelling, warmth, monitor for a fever, assess for neurovascular changes like diminished warmth, cooling of the site. That could indicate worsening of perfusion. Ongoing monitoring, document pain, neurovascular status, at least every 4 hours, if not more, due to the provider. Diagnostic evaluation, imaging, we want to do x-rays, ultrasounds, MRIs, CAT scans. Lab findings, we'll see elevated white blood cells, SED rates, CRPs. We might do blood cultures to identify an infecting organism if we believe that it's septic at this point. Therapeutic management, IV antibiotics, and it's usually long-term IV antibiotics that requires high dose IV antibiotics through like a central line or a PICC line. Early and aggressive therapy really helps prevent chronic infection, growth disturbances, and functional impairments. Next, we're going to go on to scoliosis and kyphosis. So it's scoliosis and kyphosis. Scoliosis is that S lateral deviation of the greater spine, greater than 10 degrees. It can be congenital or it could be early onset. And then kyphosis is that upper back curves forward appearing. We can have hyperkyphosis, which would be greater than 45 degrees. So scoliosis, I'm just going to be going over idiopathic, which would be congenital on this slide, and then next we'll do early onset. So congenital, also known as idiopathic, is present at birth. Severity increases over time. It's the most common type of scoliosis. It can present at any stage of childhood growth. However, it is most commonly identified during those pre-adolescent growth spurts. Other scoliosis types, we can have neuromuscular related to cerebral palsy, spinal tumors, and syndromatic, which would be like Marfan syndrome or connectives, tissue disorders. Early onset occurs in infants and children around 8 or younger. It's a higher risk for thoracic insufficiency syndrome. And what thoracic insufficiency syndrome is due to the progressive rib rotation, we get restrictions of lung growth and expansion, which means they can't fully expand that lung the way that they should, which leads to frequent respiratory issues. So with our assessment, we want to frequently monitor the respiratory. Management options, sometimes this is non-operative where we use a brace. The goal is to prevent curve progression. We can do a surgical correction, which reduces curve magnitude and preserves that lung growth potential. Kyphosis. So this is a fixed angular kyphosis. at the anterior vertebral wedge at the curve apex. There's no clear cause. It may resemble a scoliosis in pattern. The presentation is pain at the curve apex, which is also your base of your neck, and it gives kind of a rounded, hunched posture. The management is core strengthening and observation during growth. We start to use a brace if the curve is greater than 70% or rigid in skeletal immature children. Broader causes, idiopathic like syndrome, neuromuscular disorders, neural axis abnormalities, all may involve global hyperkyphosis. Surgical indications are based on the curved sides and growth remaining. Surgery if we start to have spinal cord compression or neurologic symptoms present. And from what I've heard, we're starting to see a lot more kyphosis in both children and adults due to our phones. Everybody's always looking down at devices, so it's kind of giving that premature kyphotic hump for people. So the manifestations of scoliosis, right? Either one of these, you're going to see like some type of change in the curvature of their spine. If it's kyphotic, it's going to be that hump. If it's scoliosis, it's kind of that S of their back shape. Either one of them could affect their rib cage and their chest wall shape. We could see in our scoliosis uneven shoulders and pelvic height. Those kids can also have hip and leg length discrepancy, which again, if your pelvic is kicked up, then one hip's going to be higher than the other, and one leg's going to be higher than the other. We can also see abnormal space between the arm and the trunk when they're standing upright. Additional assessment considerations from those scoliosis kids, we can see a lot of back pain, and we can also see the respiratory impairments. So, screening for scoliosis, girls screen twice, usually at 10 and 12, and boys screen usually at 13 to 14. Um, Scoliometers may be used during screening to assess for vertebral rotation, referral to orthopedics if that scoliometer reading is greater than or equal to 7 degrees. Physical examination by an orthopedist should include the entire back, shoulders, and iliac crest. They're assessing for asymmetry in the shoulder height, the iliac crest, rib hump, waist crease alignment, trunk shifting or leaning, limb lengthening discrepancy. Evaluate from side to observe for kyphosis or lordosis. Lordosis is the lumbar curve or flattened or exaggerated sagittal curve of spine. Non-surgical management, we can just do serial x-rays, just monitoring it. If it gets greater than 25%, we usually do a brace, and then we can also do surgery. And with surgery, we need to prepare the child as best as possible preoperatively. So we want to assess for anxiety related to the surgery, hospitalization, pain, appearance, and activity limits. We want to encourage the child to ask questions and express fears. We want to discuss postoperative care up front, just so that they're fully aware that they might be coming out with a chest tube. They might be coming out with a urinary catheter. So we want to give them fair warning, have them be very well prepared for it. That way they're, comfortable when they come out that they have these tubes coming out of them. Additional postoperative care, we want to monitor for neuromotor sensory function. If something changes, we need to act immediately. Remember, this is a spinal surgery. We need to assess lower extremity neurological status, pain, fluid balance, bleeding, bowel function, urinary function, wound healing. respiratory status assessment, especially if we have a chest tube present. If they have a urinary catheter in place, obviously you're gonna have continuous drainage of urine. Um, and then pain management will be analgesics. They could do regional anesthesia. Usually, post-op day 2 or 3, we switch over to oral medication. Developmental dysplasia of the hip. This will be the last topic in this slide. It's kind of extensive. Actually, no, I'm sorry. We also are going to do Clubfoot with this. Okay, so developmental dysplasia, then Clubfoot, then it'll be the end of this lecture. So developmental dysplasia of the hip is a spectrum of hip abnormalities ranging from a mild acetabular dysplasia to a complete hip dislocation. Um, so the pathophysiology, a normal hip development by approximately 10 weeks gestation, the femur and the acetabulum and the hip joint capsule are all really well developed. Most hip dysplasia develops during the second and third trimester. So the mechanism of development, the acetabulum, which is your socket, somehow becomes more shallow than normal. And this results in the femoral head, which is that ball, sliding partially or completely out of that acetabulum socket. So the ball doesn't stay inside the socket. Some degree of acetabular dysplasia is present in almost all cases. So we can have idiopathic, which is the most common, or we can have teratological, which is it involves neuromuscular defect. Usually something occurs in utero and it's less common. So again, this is you have your ball and your socket's shallow and your ball is either sliding partially or completely out. So physiological factors, they think maybe maternal hormone secretions, intrauterine positioning. We can have mechanical factors where if we have a breech presentation, if we have more than one fetus in there, if the kid has a really large infant size, postnatal swaddling with hip abduction and extension. There's genetic factors. Other risk factors seem to be female gender, family history, first pregnancy because it limits the fetal movements, breech presentation because it limits the movements and places the hips in flexion adduction. So the severity, if we have acetabular dysplasia, this is the mildest form. The femoral head is properly located, but the acetabulum is shallow or underdeveloped. In subluxation, we have partial contact only between the femoral head and the acetabulum. It maintains contact, but not well seated within the hip joint. And then dislocation, which is the most severe form, there's no contact between the femoral head and the acetabulum, and this leads to a complete displacement. So the consequences of untreated, they can have secondary changes where the acetabulum continues to become increasingly shallow. Soft tissues shorten around the proximal femur. Subluxation leads to early osteoarthritis. Incomplete dislocation, the bone acetabulum fills with soft tissue. Then we develop a false socket where the femoral head connects at the iliac crest, and during adulthood, they need reconstruction. Clinical manifestations. So newborn period, which would be birth to 4 weeks. Primary signs are hip joint laxity. And we can see a positive Ortolani sign, which is hips dislocate but reduce. So with a hip adduction and anterior pressure, the femoral head slips forward into the acetabulum, and we might hear or feel a clunk. A positive Barlow sign is the hip is reduced but can be dislocated. So with the hip abduction, a light posterior pressure, femoral head slips out of the acetabulum. The Ortolani and the Barlow test are the most reliable tests for birth to 4 weeks of age in infants. Other observable signs, we have limb length discrepancy. So the Galazzi sign is an apparent shortening of the femur on the affected side, observed with infant supine, hips and knees flex, knee on affected side appears lower. Asymmetric skin folds. So asymmetric thigh folds, asymmetric gluteal folds, can be a clinical sign of hip pathology. Limited hip abduction, so decreased abduction on the affected side, is more reliable in an older infant. Functional changes, we might see limping in our walking children, limited range of motion, or waddling gait if bilateral. Other findings, asymmetric hip height, asymmetric shoulder height, muscle prominence on convex side. Our diagnosis. So with everything, we want to start with our physical examination. Examination is kind of the mainstay of diagnosis. It must be performed on a relaxed infant for accuracy. All infants should be carefully monitored throughout the first year of life at routine well children checkups. DDH is often not detected at the initial examination after birth. We can also do imaging studies like ultrasounds, x-rays, but the absolute indicators for treatment is a positive Barlow sign, a positive Ortolani sign, limitation of abduction, apparent shortening of the femur, Galazzi sign, and asymmetric skin folds at groin. So your key considerations, screening and early detection, performing hip assessment at every well child visit during the first year, educate parents about risk factors, emphasize importance of proper swaddling techniques, hips in slight flexion and abduction. Parental education, avoid tight swaddling with legs extended, avoid forced or sustained passive hip extension in the first few months, maintain infants' knees in slight flexion during swaddling. Follow up, high risk infants require closer monitoring. Early treatment leads to better outcome. Emphasize importance of keeping follow-up appointments, understanding DDH pathophysiology, and recognizing early manifestations enables nurses to identify at-risk infants and facilitate timely intervention, which is critical for optimal outcomes and prevention for long-term complications. This is just kind of giving you a visual understanding of what the Ortolanis and the Barlows looks like. So remember, Barlow's is adduct the hips and gently apply gentle pressure downward and backward with thumbs in hip. With hip dysplasia, the examiner can feel the femoral head move out of the acetabulum. The Ortolani's is the one that's going to have a clunking sensation, which indicates a dislocated femoral head moving into the acetabulum, and that's abduct the thighs and apply gentle pressure forward over the greater trochanter. So the nursing care for this, all infants should be assessed at routine visits. We want, once they're diagnosed, the nurse assessment focuses on parent knowledge, anxiety and coping, adherence to treatment, monitoring skin. We're going to be putting the child in either a Pavlok harness or a spica cast. So with the Pavlok harness, position and we need to position and fasten chest halter. We need to leave 2 fingers under the straps, shoulder straps crossed in the back. Allow 1 finger under top straps. Place leg and foot into stirrup for secure straps. Connect leg straps to the chest halter. It's worn 23 hours a day and removed only as directed by the provider. We need to do a lot of education on the harness being worn 23 hours a day and the risk for irritation and skin breakdown. So we need to teach the family to check the skin routinely, report changes in skin condition, and maintain integrity throughout treatment. And this is just a little image of the padlock harness. And then this kiddo is in the spica cast. Spica cast is going to be a hard cast, and they require a special car seat. So a little bit more about the spica cast. Spiky cast, caring for these kiddos is similar to caring for other casts, but requires some additional adaptations. The cast covers the entire lower half of the body, leaving only a small perineal opening for elimination. And that can become very challenging. So it's skincare. Excess urine can collect under the cast, cause skin irritation and maceration of our skin, can be really difficult to dry, and it become very malodorous. So we need to teach the family to tuck a disposable diaper under the cast edge at the perineal opening. Do not use a sheet of plastic under the cast, because then it leads to urine pooling and skin breakdown. We can also place a sanitary napkin inside the diaper for additional absorption. We want to make sure that we elevate the head of the bed to help the urine and stool drain downward and away from the cast. Neurovascular status with this cast. So we need to monitor neurovascular status frequently in the child with a cast. We need to teach the family the key signs of neurovascular compromise, which can be that increased pain, tingling, swelling, changes in color. We can also start to see like fever, wound drainage, or discomfort that could indicate an infection. So, promoting positioning and development, we want to encourage the family to provide environmental and developmental stimulation, moving the child to different areas during the day, placing appropriate toys within reach, and offering age appropriate activities. We want to ensure the extremities in the cast area are supported at all times, using pillows, rolled towels, or a beanbag chair for support. And again, this is a hard cast that will require, for if they're taking them on a car ride, to have a special car seat. Clubfoot. So clubfoot is a congenital foot deformity in which the foot turns inward and downward. It's the most common pediatric foot deformity. It can be diagnosed during our prenatal screenings. Clinical manifestations, we're going to see that visible deformity where the foot's turned inward, downward. It really varies in position. Usually the sole is facing medially. The affected foot and calf may appear smaller than the unaffected side. Functional impact, if it's not treated, will be difficulty in ambulation, walking on the side or top of their feet, abnormal gait patterns, pain and callus formation, and then eventually long-term disability. The treatment for this is the point setting method, which is the golden standard. And this is serial casting that begins shortly after birth with weekly gentle manipulation and stretching of the foot. Serial long leg casts are applied to gradually improve the foot alignment. Extremities are casted until maximum correction is achieved. It's usually within 6 to 10 weeks. Families will experience a lot of challenges with this treatment. Your nursing care focuses on education and anticipatory guidance. Again, this child is going to require serial casting each time with manipulation. Parents need to be provided with information about the condition and the treatment to kind of help reduce their parental anxiety and guilt. It helps improve treatment adherence and patient outcomes. We want to make sure we're using lay terms, not scientific language. We want to explain that, the cause is not fully known, but when we do this treatment, the foot should have normal development, and the child is expected to have normal development. We want to teach neurovascular assessments, skin assessments, pain assessments, give clear verbal and written instructions about positioning, bathing, and skincare. We want to make sure that the child is being supportive. We want a calm, quiet, warm environment. In the tendon or Achilles lengthening, which is required, sometimes we need to pre-medicate with a local anesthetic to reduce pain. Um, and then if we have to do surgery, we want to manage our postoperative pain, elevate the feet to reduce swelling, administer those pain medications, and then assess neurovascular status at least every 2 hours. We want to advocate for our client and their families, and family involvement is really important. So we want to make sure that we're reinforcing treatment steps and providing ongoing encouragement, lots of phone follow-ups, lots of regular follow-ups. Remember, this is going to be those weekly castings for 6 to 8 weeks. So we're going to get to know this kiddo a lot. Again, the standard treatment is that point study casting method. Treatments will be that gentle stretching and manipulation to realign those bones. A well-molded long leg plaster cast is applied after each manipulation, and that helps maintain the correction and allows soft tissue relaxation. It supports atraumatic remodeling and abnormal joint surfaces. After casting, the foot can sometimes appear overcorrected, and then the child might end up wearing a full-time brace for 3 months, and then eventually just a nighttime, 12 hours nightly, at least until the age of 2, to prevent reoccurrence of the deformity. And that is the end of this lecture. Next one will be skeletal growth disorders and juvenile arthritis, and one or two other topics.